Hello, everyone. This is Chadi Alraies coming to you from RSH 2026. I'm privileged to be with Dr. Sticchi to talk about patient selection and intervention for tricuspid valve. Dr. Sticchi, thanks for being with us again this year. Welcome to Riyadh.
Thanks so much, my friend. It is always a great pleasure being here. The meeting is amazing this year once again, and yes, the tricuspid field, tricuspid intervention field, is becoming more complex, probably also than the aortic one. This because the literature is exploding. Studies are trying to hit the very deep of the knowledge of these procedures, of these interventions. The tricuspid patient is a complex patient on both anatomical and pathophysiological side. The two things going forward together. So we always have to take in consideration not only the technical part, so the anatomical screening, the annulus dilatation, the ventricle, the atrium, and the function of the right ventricle, but we have to take in consideration the stage of the disease according to the pulmonary function, so the RV-PA coupling, and also the stage of the congestion, the systematic congestion of the patient.
So basically, like before, once you define a problem and severity are, right heart cath become very
right heart
important.
catheter right heart catheterization is fundamental. We cannot proceed forward without having all the data. So anatomical data, so CT whenever possible, or MR is a good alternative in a patient with high level of creatinine and very low kidney function. Right heart catheterization, and also systematic screening of the frailty of the patient. This is also very important. And then we can proceed to consider which kind of intervention we can propose to the patient, and should be also, as the last European guidelines from my mentor Fabian Prats said, that the patient should be involved in the discussion, because sometimes patients want to have a short hospitalization. Sometimes they don't want to approach a long-term anticoagulation that is fundamental for replacement. So repair and replacement, we have two possibilities. First should be repair, because the repair is so safe right now. So if the repair is approachable, feasible, we have to try with the repair first. But if the repair does not guarantee, as in the pre-evaluation phase, a successful rate that is considerable, we should switch to replacement, and we have a completely open scenario when you decide to switch to the replacement, or also to some different strategies such as the heterotopic replacement. It is still a open, valid field, so we have to consider all.
And this discussion usually happen with the surgeon as well as with the patient before you take the patient. And have you made a decision like in the procedure where the repair didn't work and you have to replace, or usually you stop, bring the patient back?
No, I totally want to suggest a stage approach, step by step. First, the discussion when we have all the data. Then, if we are ready to consider it, two things: the anatomical variability of the valve. So, if we have 3 leaflets, 4 leaflets, probably replacement is your choice, is your best choice, because the rate of failure of the repair in 4 leaflets valves are very high. And if you have more than moderate, or even moderate sometimes, residual tricuspid regurgitation, you have a failure, because the prognosis of your patient is very poor. So that is the moment that you have to consider replacement. And replacement is not an easy field right now, because now we understand it, that now we understood that we have to consider long-term anticoagulation, potential rhythm disorders. And in these categories, you have to consider not only patient with RBB, but also patient with a previous lead, because it's not sure that you can implant safely at mid-long term a valve in a patient with a lead. The lead should be carefully considered for the position, the orientation, the tension that it has. And we have we have studies with a 42% of issues after the implantation about the lead, because there is a mechanical problem in the contact between the prosthesis and the lead. So we have to be very, very careful. And then there is the problem of the afterload mismatch, because sometimes we are seeing this phenomenon not only in patients with RV poor function and high pulmonary pressure, but also in patients with normal pulmonary RV PA coupling. So we have to be very careful.
Yeah. Well, Dr. Sticchi, again, a great overview of selection and intervention, clipping or repairing or replacement for patient with severe tricuspid regurgitation. Thank you for your insight, and watch these videos and others on the YouTube channel. This is Chadi Alraies coming to you from RSH 2026. Dr. Sticchi, thanks again.
Thank you very much, my friend.
Thank you.
Thank you.